let's talk for a minute about multiple myeloma, which technically is a lymphoma. Multiple myeloma is a cancer of plasma cells, which are B cells, B lymphocytes, at the most kind of mature phase of differentiation. Recall from A&P that B lymphocytes will eventually mature into one of two things: a plasma cell, which is basically a cell that contains antibodies, or a memory B cell. Multiple myeloma is a cancer of plasma cells. All right. Just like lymphoma, multiple myeloma is a cancer whose pathology rests upon genetic alterations. So a B lymphocyte has to take on a certain number and the right amount of alterations to its genome to take on cancerous characteristics. One thing to know about multiple myeloma is that it has a preceding pathologic condition, and that condition has a horrible name. It's right down there at the bottom, and it's called monoclonal gammopathy of uncertain significance. Yes, MGUS for short. MGUS is actually so common and inconsequential in people that 90+% of the people that have MGUS will pass away of something else, never knowing they had MGUS. All MGUS is a few genetic alterations in plasma cells that basically create plasma cells that have antibodies that don't really do anything. They don't really help in terms of your immune response or fighting off infection. But they're not really doing anything bad. They're just there. A small percentage. The only reason I mention MGUS is because a small percentage of MGUS patients that kind of have that foundation of chromosomal translocations, where you take a piece of a chromosome and put it somewhere else, or hyperdiploidy, extra copies of chromosomes. They have that foundation. A very small percentage of MGUS patients go on to develop multiple myeloma. But to do that MGUS plasma cell has to take on more translocations or sustain some mutations to oncogenes. And I list two of them there, the MYC oncogene and the RAS oncogene. Probably the most important thing to remember here, if we haven't discussed it already, is that cancer is often a result of either overexpressed or overactive oncogenes, genes that regulate growth, or the loss of tumor suppressor genes, genes that suppress or control growth. And there's kind of an imbalance then between those two. Clinically, when patients have multiple myeloma and the correct kind of genetic pathology is occurring, clinically these patients will present with what's called the CRAB criteria. And this is a great acronym to cement into your brain. CRAB stands for hypercalcemia, renal damage, anemia, and bone disease. So we'll start with bone disease. The malignant plasma cells are known for stimulating osteoclast activity. And remember from A&P, you have osteoblasts and osteoclasts inside your bone. By stimulating osteoclast activity, you get essentially these things called lytic lesions, where there are basically porous spots within a person's skeleton. I should say that multiple myeloma is very often diagnosed initially through a pathologic fracture from the plasma cells getting in, stimulating osteoclasts, and creating these lytic lesions. So that's one common presentation for multiple myeloma. As the lytic lesions are breaking down bone, they're releasing calcium. So the blood calcium level starts to rise, and there's all kinds of clinical manifestations to that. One of the most common is generalized muscle weakness. The kidney damage is a bit multifactorial. The kidney damage can be produced from calcium stones, from hypercalcemia, so you can get stone related kidney damage. You can also get something called protein nephropathy. I'll discuss that a little bit more because it's a hard one. As the multiple myeloma plasma cells are growing and dividing, some of them are dying and releasing their antibodies, which are just a bunch of proteins. And those have to get filtered out by the kidney. The kidney normally can handle a certain amount of protein within the nephron, but if it becomes overwhelmed, the nephron can be damaged by excess amount of protein in there. And protein nephropathy can be a contributor for renal damage in multiple myeloma patients. The anemia in CRAB, or CRAB criteria, is also multifactorial. So the first thing that contributes to anemia is plasma cell invasion of bone marrow, suppressing normal bone marrow function. That's number one. Number two is in patients with significant renal damage, their erythropoietin production falls and bone marrow is no longer getting stimulated to produce adequate red blood cells. There's a lot involved in CRAB. So I've mentioned this kind of abnormal plasma cell containing an abnormal antibody, but I haven't really mentioned a name yet. That abnormal antibody is called the myeloma protein, or the M protein for short. And this is what antibodies look like, including M protein. As that protein is broken up and essentially goes to the kidney and gets washed out, you will find either constituents of it or entire M protein in your patient's blood and urine. A long time ago, the first thing that basically smaller protein molecules can be lost in the kidney before larger protein molecules can. So a long time ago, when multiple myeloma was initially discovered, diagnosed, and workups were done, Dr. Henry Bence-Jones was the first person to identify the presence of what are called light chains within multiple I can't talk today. Multiple myeloma patients' urine. And to this day, those light chains are referred to as Bence-Jones proteins, named after Dr. Henry Bence-Jones, who initially identified them, as the story goes, by boiling patients' urine and finding this kind of protein precipitate left over. As kidney damage goes on, patients may lose the entire M protein within the urine as well. But when you measure a person's blood, you can measure Bence-Jones, you can measure M protein, intact M protein, but it's all reflective of how much malignant activity is going on within your multiple myeloma patients. In addition to that, of course, multiple myeloma patients are going to have CBCs done to check and see how well their bone marrow is doing. They're going to have blood calcium levels checked, of course, and to really diagnose the disease, you got to go into the bone marrow, dig out some bone marrow, and see if you can find malignant plasma cells.